Hi, this is Elliot Fishman, and welcome to part 2 of our talk on benign polypoid gastric masses. We stopped last time mentioning gastric schwannomas, which are also known as neurolimomas or neuromas. They're uncommon benign tumors. Well under 1% of all gastric tumors, they arise from Schwann cells. Typically, the patients are in the 5th decade of life, more common in women. Their average size is in the 3 centimeter range, and I think one of the challenges with them, they look very much, when you look at them, as GIST tumors, and since we do see GIST tumors more commonly, it's more likely for us to come up with a diagnosis of a GIST tumor, and actually, usually it's on the surprise, on the pathology report, after we've dictated a GIST, it comes back a schwannoma. They can present with incidental finding, but they can present with GI bleeding, dyspepsia, epigastric pain, or sometimes they get large enough to be a palpable mass. Because they're similar to other stromal tumors, it's often difficult, as I mentioned, to make a definitive diagnosis. They're usually solitary, but can be multiple. Here's a nice example. I showed you a case in the first part of a mass in the gastric wall that's intraluminal and exophytic, homogeneous. I look at this case, I read this, I said this is a GIST tumor. I've seen many GIST tumors, 4 or 5 centimeter range, exophytic, intraluminal. Remember, most GIST tumors grow exophytically, but they also can go intraluminal as well. This was resected because of its size, and it came back a schwannoma. Again, it's a benign lesion. To me, it looked like a GIST tumor. Another example, larger mass, soft tissue density, relatively homogeneous, coming off the stomach. There it is, nicely shown there. It's not from the pancreas. It's not from the mesentery. Again, a very nice soft tissue mass, mainly exophytic. I read this tomorrow morning. I'm going to say a GIST tumor. With a little bit more experience, maybe I'll say this is likely a GIST, but it can be a schwannoma. If I was a well-done AI program, I would put down GIST tumor 97%, others 3%, and in the other category, schwannoma would be at the top of the list. And again, just a really nice example showing you why there's such a challenge, because they look like GIST tumors. And here's another one. This one has a small ulceration, but a beautiful example of a intraluminal and exophytic lesion, just what I expect to see with a GIST tumor. We talk about GIST ulcerating when they get larger, they can bleed. So again, I read this one, and I would say this is going to be a GIST tumor. This was also a schwannoma. So I've shown you several schwannomas, okay? Here's another lesion in the fundus. Could this be a schwannoma? Could this be a leiomyoma? This was a GIST tumor. I just show you this case just to remind you that it's not as easy in practice. Now, I think at the end of the day, you are going to get a biopsy. If the lesions are larger, they're going to be resected, and it's going to be in the hands of the pathologist. Those larger lesions I showed you, whether they're GIST or schwannomas, they're going to be removed. The good thing for the patient, of course, is if your lesion ends up being a schwannoma, there's not going to be any concern for malignancy, things like that, and so you will get surgery, and it'll be a one and done. So that becomes very, very important. Now, when we talk about submucosal masses, again, we talk about these schwannomas. What can be helpful at times is separating from GIST tumors, but you know, the things people have looked at, progressive homogeneous enhancement pattern is more common in schwannomas, but I have to admit, most of the cases we do in this scenario, particularly when they're incidental findings, are single-phase studies or they're dual-phase arterial venous. We're not getting 7 or 6 minute delayed phase scans on routine abdomens. So this idea about increased enhancement over time in schwannomas is something good to think about, but the reality is we don't do it. Now, perhaps if you were looking at a lesion and the patient was still on the scanner table and you saw the lesion, like we did in the old days, you might say, let's wait 5 minutes. And if a lesion goes from 30 to 50, and then on venous it's 50, and then you go and it's a GIST. On the delayed, it would be probably 45 or 40. If it was a schwannoma, it would go up to 70. But again, that's not what you're going to be doing, but it's something interesting to think about. Now, another lesion we talk about that's a great mimicker is heterotopic pancreas. It's defined as a developmental anomaly where pancreatic tissue is outside the pancreas with no anatomical, vascular, or contact with the normal pancreas. They're most common in the duodenum, but can occur in the duodenum, stomach, or jejunum, and they can ulcerate, and they can be a great mimicker of other pathologies. In terms of how often you see them, if you have autopsy series, they talk about 0.5 to 13%. I've seen a couple in my day. Now, maybe these little tiny things you see in the stomach or duodenum that you ignore are ectopic pancreas, but indeed, it's extremely unusual. The most common symptom is abdominal pain due to endocrine function of the ectopic pancreas. They can cause complications such as stenosis, ulceration, bleeding, and if they get large enough into susception. There are case reports of larger lesions in the prepyloric region causing obstructions, though I've never seen that. Here's a nice example of a submucosal lesion. Again, I might think about a lipoma, but it's not fat density. There's an enhancing rim. Could this be a leiomyoma with some ulceration? Could this be a small GIST tumor? This ended up being on biopsy and finally resection, heterotopic pancreas. Again, a very, very unusual appearance. Here's a more typical one. You see what looks like a soft tissue mass. You could think about an implant if you had metastatic disease. That's rare. You could think about a leiomyoma. Good thought. Probably my best thought. You could think about a GIST tumor. That's also a very good thought. Smooth, well-defined, interluminal positioning. Well, guess what? This was a heterotopic pancreas. Now, we mentioned heterotopic pancreas, particularly on early phase imaging, can be very vascular and then washes out. It's interesting if you look at this case and you look at the pancreas, it's not quite as bright as the pancreas, but it's pretty close. A really nice example and a classic example of heterotopic pancreas. And here's another one that looks very similar. Again, a polypoid lesion, slightly vascular. Again, you go through a differential, but if you see this and you're really complete, heterotopic pancreas is a good thought. If you're on a film panel and you see a polypoid lesion, you better mention heterotopic pancreas as a possibility. Now, there's some unusual, wild, and crazy things I like to say. Gastric antral vascular ectasia, or GAVE, is one of them. We talk about this from the endoscopy perspective, calling it a watermelon stomach back in 1984. Another endoscopic pattern talks about a honeycomb pattern. It's a rare condition that can lead to GI bleeding because it's very vascular, and typically it's in the antrum. And CT has a unusual appearance, but one that could make you think of the possibility. Way back when, we published an article about this. Bruce Urban, we had an interesting case, which was a bleeding area on endoscopy, and eventually it was proven to be a GAVE. We thought it was a GIST tumor, and that's probably much more logical because it's much more frequent. I don't think, except in a group setting at a film panel, I've ever prospectively made a diagnosis or even suggested the diagnosis of a GAVE tumor. But here's a nice example. This vascular lesion in the antrum of the stomach. There it is here and here. You could think about maybe a carcinoid tumor or some other vascular lesions. You might think of a GIST, but it's very, very vascular. But occasionally we do see very vascular GIST tumors. And again, you can see it's in that antrum. Really impressive. That's a classic appearance. And here's that article. Brown Jones, Bill Ravitch, Scott Kern, Bruce Urban, I mentioned, 1991. Well, I don't think I've seen maybe more than one case since 1991. And in that article, in our patient, the findings of prominent mucosal folds extending from the pyloric channel on the upper GI series and the thickened antral wall on CT correlate well with the known vascular pathologic appearance of gastric antral vascular ectasia. Again, very unusual, but in that differential of benign gastric polypoid-like lesions. And here's just another one that looks very similar. Again, hypervascular lesion in the antral region, somewhat polypoid. There it is, very nicely shown on the coronal view as well. It almost looks like it's intussuscepting into the antral region. Looks very similar, almost identical to that first case. And again, the vascularity, and this was GAVE. Okay, really, really unusual. Now, one thing we did not talk about in the article was gastric duplication cyst, and I thought I'd throw that in as the last case. You can have duplication cysts which can simulate masses. Most of the time they're exophytic, and so you know it's outside the stomach, and you wonder if it's something in the mesentery, maybe from the pancreas, or maybe from the stomach. The clinical picture depends on the size and location and the presence of communication with the alimentary tract. And duplications of the stomach are pretty rare. When they do occur, they present in infants, and patients then present with vomiting and abdominal pain, and they're typically resected, though we've seen a number of cases of duplications in adults, usually by the greater curvature. It's very uncommon. Again, patients usually present in infancy or under age 5, but it can occur in adults. They can get larger. Maybe that's why they present when patients get older. They have no potential for malignancy, and they're typically symptomatic, which is how they present, and then they'll be removed. Occasionally, you'll see a duplication cyst, which is an incidental finding, and then, it's more the workup that needs to be done. Here's a nice example of a large cystic lesion pushing on the fundus of the stomach, well-defined water density. Differential, you could think about a pseudocyst coming off the pancreas. You could think about old trauma, perhaps. You could think about a prior bleed, but very well-defined, sharply marginated, pushing on the stomach. Just a really good example of a duplication cyst. If it looked like this and it was off the duodenum or jejunum or ileum, you would say a duplication cyst of the small bowel. But this is a very nice gastric duplication cyst. So we've looked at a range of benign gastric masses. I recommend you read the article. We talk about glomus tumors and leiomyomas and schwannomas. We spoke a bit about cyst tumors. We'll speak more about that when we have our next set of lectures after the next article comes out, talking about polypoid lesions of the stomach that are malignant. We talk about really unusual things like GAVE lesions. We talk about duplication cysts, which typically are not going to be a difficult diagnosis because they're cystic and their appearance is totally different. So in that, go back and read the article, think about the various lesions, and I think you'll do a great job when you see those cases in your clinical practice. And with that, I thank you for your attention and have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.